have the
Oh my
Polish,
God,
now
yes.
we're going to go for the Russian.
You didn't tell me that we're going to.
Hey, man, we don't have to tell Russians. They always bring the party.
Need to be 7 p.m. somewhere, mostly in Russia now. It's midnight. You should be drunk already.
All right. All right. So.
All right, my friend, jump in.
Share
Thank
my
you so much for being here.
screen. Where's the presentation? Give me 1 second, guys.
No problem.
All right. It's scary here. All right. So that's
Beautiful. That's the one.
all right. I'm ready. Let me know when.
What time is yours? Go for it. One. Ah, you were waiting for that. You see, people get enthusiastic. 1, 2, 3, go!
All right. So we're gonna switch the theme a little bit, and we're going to talk about surgical part. It's welcome welcome to Boston, and thank you for inviting me to talk. And I'm very excited to share with you the results of the study what we did several years ago at Boston Institute of Aesthetic Medicine in Moscow. We have this office there. And I did this study with my oral surgeon, Dr. David Nazaryan. And this study was supported by the Russian National Center of Surgery. And we will talk about the application of electromyography and computerized mandibular scanning for evaluation of masticatory and TMJ function in patients with mandibular defects after outer transplantation of the lower jaw. And you understand, we all understand that objective data is very important for us. And this presentation is devoted to the role of the neuromuscular diagnosis in a comprehensive algorithm utilized in treatment patients with mandibular deficiencies. It's particularly concentrated on a clinical case in which neuromuscular evaluation was used to confirm the attachment of the muscles involved in mandibular movement to transplanted bone used to restore defects of the mandibular after surgery. Also, electromyography and computerized jaw tracking were utilized to conduct the proper evaluation of both level of the functional restoration of the attached muscles as well as the function of other components of our system. And we had 34 patients like this woman, and this particular patient has a partial defect of the lower jaw after resection of the portion of the ramus and the body of the lower jaw as a result of osteosarcoma. And so you can see that the big portion of the lower jaw was removed, and the frame, they put the frame and then bone graft, and then we restored this patient. This is another patient with osteoblastoma of the mandibular, and also she went through extensive surgery, but this pictures before it was removed, osteoblastoma was removed. And we used electromyography, computerized jaw tracking. For some patients, we using sonography in order to evaluate muscles, TMJ, the status, and the range of mandibular motion for these patients. And for some of you who probably not familiar with all this K7 evaluation system, we use electromyography and jaw tracking to find out what's going on with function of the muscles and the joint. Also, we use ultra low frequency TENS, and we use 2 channels activated cranial nerves 5, 7, and 11. And again, I don't know if somebody never used this. So basically, we placed the myotrodes, electrodes on a projection of the nerves, and the nerves transmitted this electrical signal to the all muscles of mastification. So this is what we used to relax muscles and to help us to find the proper position of the lower jaw. Basically, TENS doing 2 things for us: muscle relaxation, and on another hand, inhibition of the pathological ingrams, like temporary inhibition. And as a result, muscles move the lower jaw on a physiological neuromuscular trajectory in a position of the physiological rest. And we use this position to define optimal occlusion. We use this position to treat TMD problems, for TMJ decompression, to physiotherapeutic treatment of TMJ symptoms, occlusal adjustment, removable prosthesis, treatment of sleep apnea, and et cetera, et cetera. Unfortunately, my screen is kind of limit the space. So in other words, we use TENS all the time. But for this group of patients, it was very important to shorten the time of the TENS, and we used another technology to help get a muscle relaxation, like NewCam. And when we're talking about NewCam, the main component of this system is this neuroacoustic software. This neuroacoustic software activating the parasympathetic response, and as a result, our system works on a theta, alpha theta crossover, so with very low frequency, and because of this, we're getting deep relaxation of the muscles. So, and we use this technology and to get deep relaxation and reduce muscle tension. This is the main reason why we use this acoustic program. And you can see this electromyography on the left. You can see the high numbers, 3.93 and 3 microvolts. This is the hyperactivity of the temporalis muscles, upper 2 lines. And after 10 minutes of using TENS and NewCam, you can see it's at rest. It's less than 1 microvolt. So it's pretty much relaxed, and we can start to work with these patients after basically 10-15 minutes. And I will share with you a couple of patients out of this study. This is a young woman, 23 years old, woman with osteoblastoma, pretty big size, and this osteoblastoma was removed, and titanium frame, like temporary, they put a titanium frame to hold the fragments of the mandibular, otherwise it would collapse, and it's difficult then to restore the shape. And one thing I want to show you with this patient, if you take a look, this is a bone graft. They took the material from iliac crest and used this material to form the bone transplant. And they put this bone transplant there. And I want to show you, you can notice that this transplant doesn't have a coronoid process. And 2 months later, you can see that, actually not 2 months, it's like 2 years later, you can see the hypertrophy of the coronoid process for this patient. So, and as we know, it can happen when we have a muscle attached to the bone, and it's supposed to be some activity, some hyperactivity of these muscles. So, and you can see here more clearly this coronoid process after a certain period of time. So it means that muscles are most likely attached here to this to the coronoid process. And this second case I want to show you, this patient with a defect on the left side of her lower jaw after fibrosarcoma resection. And you can see the facial asymmetry, parafunction of the masticatory muscles, asymmetry in the middle of the lower third of the face, and some indentation impaction in the cheek and submandibular area. So we see all these defects. Also, this scar what she had on the submandibular area causing deformation, along with missing some part of the hard tissue. And we see the hypertrophy of the muscles on another side, on the right side, on the healthy side, and atrophy of the muscles on the left side where the surgery was done. So, and this is a condition we have in the mouse. Basically, we can call this as an open bite, missing a lot of teeth on the left side, and the remaining portion of the lower jaw shifted in relation to, for example, optical plane. Since nothing was placed here to maintain the position of the remaining part of the lower jaw, now we have to deal with this type of deformation. So, and what we did, before I tell you what we did, so the CT scans confirmed this hypertrophy of the masticatory muscles on the right side and the atrophy on the left side. You can see the difference. So we use fibular bone to create grafting materials, and after 3D planning, we shift the remaining portion of the mandible into the, let's say, more physiological position. We use computer modeling to determine the correct position of the condylar process and form graft, and we took in consideration the future fixed prosthesis what we plan to to do. So this is how this modeling used. And don't forget, this was like 5 years ago. It's more advanced technique we're using now. So then templates were made for precise three-dimensional graft modeling. And this is a procedure was done. You can see the graft material and how we form the piece of the bone of the mandibular, and then they placed this surgical team, and this is after picture immediately after surgery. You can see that graft was precisely positioned in the temporal fossa. And immobilization was achieved by maxillary splinting and placement of the mini implants there. This is how we hold it. Also, to move the pieces of the bone for this patient, we use TENS, and we use Botox to kind of overcome the tension of the muscles. 2 days after the procedure, despite the fact that we put all this retention in, rotation happened of the lower jaw because of muscular hyperfunction on the right side and lack of the normal muscular function on the surgical side. So, and it took us then some time to put the lower jaw, the right fragment of the lower jaw together. You can see the shift, what happened. But we did, again, we use Botox, we use mini implants, and finally we kind of correct the position. After a certain period of time, we saw the stable position of this fragment, and we placed implants, and then implant supported fixed restorations. So this is was story about this patient, and masticatory muscles on the surgical side left had attached to the transplanted bone. We confirmed this with a CT scan, and then we did the electromyography. In the rest position before TENS, you can see some hyperactivity, hypertonicity of the temporalis muscles, and this hypertonicity most likely happened because of distal position of the mandibular and sufficient height of the bite. And also on the right side, it was 23% tonicity higher than on the left side, and this most likely due to temporalis compensating for the masseter on the right side. But for this patient, after TENS, you can see the scan 10, and the muscles looks pretty normal at rest. Pretty normal at rest. Also, clench, we can see that masseter started to work, because you can see the higher number on a second clench after TENS. It's a little bit better. Computerized jaw tracking showed a slight limitation of the mouth opening and deviation of the mandibular to the left, when patient opens her mouth. It's understandable why, but as a result, based on the data obtained using neuromuscular evaluation CT scans, it can be concluded that not only have muscles attached to the graft, but also that they begin to restore their function. So, and this is a story about this patient. This is another patient, woman, 33 years old. It's pretty much the same steps, but in her case, we placed frame right away, and we didn't have any problems with the remaining pieces. All planning was done prior to surgery. Tumor was removed. A pretty big piece of lower jaw removed, and you can see the graft material. And we placed this graft material in place of removed part of the lower jaw. This is a picture 2 months, 2 months, I believe, and we did a temporary removable denture and placed implants and made temporaries. Again, CT scan confirmed that the masticatory muscles from the surgical side had attached to the transplanted bone. Computerized jaw tracking with a K7 equipment showed us the normal opening. It's a little bit limited lateral movement of the lower jaw. EMG confirmed that muscles attached to the graft were responding in accordance with their function, and they capable of normal function, and they is give it the normal muscular tone and contraction. So 3 years later with this patients, it's everybody happy, but she still had a temporary for this 3 years because of some financial issues. By the way, everything what was done for free for the patient until this point, and she didn't have any symptoms at that time, and pretty good function, chewing function, conformed with electromyography and jaw tracking. You can see the normal function and joint during opening and closing with a high terminal velocity, normal amplitude of mandibular movement and movements, and no symptoms 3 years later after the surgery. A good chewing cycle, no interferences. And also good, decent EMG, occlusal stability, and no muscle hypertonicity. I'm talking about temporalis muscles, okay? So in conclusion, electromyography and computerized mandibular scanning in patients with mandibular defects after outer transplantation of the jaw bone can be used to confirm the muscle's ability to attach to the graft. The attached muscles are capable to contraction and maintaining their muscle tone, and electromyography and computerized jaw tracking allow proper evaluation of the level of the functional restoration, and work of the muscles and joint. And we know now, because it was opinion that muscles can't attach to the transplanted bone. So, and this work showed that yes, it can, and electromyography actually helped us to show that the muscles start after a certain period of time start to function, and they can function if they're not attached. So that's the beauty of objective data. We can prove what we talking about, and we can determine the treatment. And now we use this protocol for all patients to rehabilitate them after surgery, like I showed you before. And basically, I believe that's it.
Thank you so
This
much.
is
Very
so
interesting.
crazy.
It's unbelievable.
I hope